So we're here at the 2024, the first ever Cell Coast Conference, sponsored by Moffitt, looking at CAR T cells and the treatment of various diseases. I'm here with Dr. Bijal Shah, who's an expert in the treatment of acute lymphoblastic leukemia, and it's really great to have you here, so thank you for sharing your expertise. I wanted to ask you a question about ALL. Tell us about the use of CAR T cell therapy in the relapsed or refractory setting of ALL.
I think one of the nice things that we're seeing is that the use of CAR T cell therapy is now being moved up. We're no longer seeing it in the multiply relapsed refractory patient. We're seeing this shift, now to earlier and earlier lines of therapy. We're seeing it integrated with lower tumor burdens, and I think as a consequence, we're really seeing just incredible output. We know that once a person relapses with ALL, we're talking about standard chemo, their long-term survival is less than 5%. And we're talking about one relapse. We start talking now about second, third, and so on. All we're doing is pulling that number down even further. So now being able to bring that CAR T forward, integrate it early, seeing the incredible survival that we're seeing, and again, to put some numbers around it, it's upwards of 70, 80% as we start integrating it in these earlier lines of earlier settings. It's remarkable.
So people often think of ALL as a disease of younger people, children, things like that. But what's not as well known is that older patients often have very difficult to treat ALL. Tell us a little bit about your experience with CAR T cell therapy in the older patient.
I'm really glad you asked. I think that's a really, really important question. One, we know that immunotherapy works. We have the blinatumomab data, and now the inotuzumab, followed by blinatumomab data that were developed by the cooperative group, showing, this is a population where immunotherapy can be a benefit. The challenge with those trials, though, even integrated into newly diagnosed disease, half of the patients are relapsed, right? I mean, they're going to relapse with these, again, pivotal, incredible therapies. CAR T cell therapy absolutely has a role to play in this space. Initially, there was a concern about toxicity and benefit. What we've seen is, and I don't know why, but what we've seen is actually, if anything, those patients 65 and older seem to do better. We now have two back-to-back frontline relapse refractory trials. We have ZUMA-3, where the response rate in those 65 and older was 100% CR/CRi. Now we also have the obe-cel data, 95% CR/CRi. So certainly nothing to fear from an efficacy standpoint. What about toxicity? Interestingly, the things that we focus a lot on in CAR T, we talked about persistence during the meeting being one of my pet peeves. Acute toxicity is also one of my pet peeves because the overwhelming majority is reversible. So, when we talk about cytokine release syndrome, we're at a point in time now that we're better at managing it, we're better integrating our anti-cytokine therapy early, and we're going to see an improved output as a consequence. ICANS is still something that we're learning to navigate. I think we're going to get to the same place, honestly, in the next couple of years as we start bringing interferon gamma inhibition forward and other novel approaches forward. But all of it is to say that ICANS in most patients is still, we're talking about 2 or 3 days. So, for the really complicated patient, yes, there's still a concern there. And I don't care if you're 65 or 25. If you extend that hospitalization, if you have someone who's, again, not eating, drinking, and walking, that toxicity is going to matter, right? Because we're going to talk about rehab and those things on the back end. Importantly, we're still seeing a clinical benefit. People will recover and are likely to recover in a complete remission. And so this is the real take-home message. There are acute toxicities. There are some who have more severe acute toxicities. We're learning to manage it, but regardless of all of that, these short-term acute toxicities are not a reason to avoid curative, life-saving therapy in this situation. Wrong answer, but you hit on a pet peeve, so I had to tell you that.
Well, thank you very much. Really appreciate all your expertise, and we're really looking forward to the results of the frontline trials coming out over the next few years. So Thank you for speaking with me.
Thanks, man.